I am Tayyiba Akbar. My roll number is BP1650236. My group number 32 has been assigned with the acute renal failure, and I have to prepare the case study on angiotensin converting enzyme inhibitor induced acute renal failure. Now, starting with the disease, that what is meant by the angiotensin converting enzyme inhibitor induced acute renal failure. Angiotensin converting enzyme inhibitor are prescribed in hypertension, cardiac arrest. Its hemodynamic effect will result in the decrease of the blood flow through the unit mass of the renal tissue, or there is increase in efferent arteriole surface area that it will be dilated. What are the angiotensin converting enzyme inhibitors? The angiotensin converting enzyme inhibitors are prescribed in chronic heart failure, hypertension, as it relaxes the vein and arteries and decreases the blood pressure. It prevents an enzyme to produce the angiotensin 2, which is responsible for narrowing the blood vessels. How the action of the angiotensin converting enzyme inhibitor is produced. Renal, which is primarily released by the kidney, stimulates the formation of the angiotensin in blood and tissues, while this angiotensin 1 will be converted into the angiotensin 2 through the action of the angiotensin converting enzyme, which will result in the increased level of the aldosterone, sodium reabsorption, blood volume, cardiac output, and increased level of the blood pressure. If we have any angiotensin converting enzyme inhibitor, it will inhibit the action of the angiotensin converting enzyme and prevent the formation of the angiotensin 2, which is the active vasoconstrictor, ultimately result in the decreased level of the aldosterone, sodium reabsorption, blood volume, cardiac output, and the blood pressure. Different angiotensin converting enzyme inhibitor drugs are listed below, which include the captopril, enalapril, posinopril, moxapril, and the other which are mentioned in the slide. How the angiotensin converting enzyme is inhibitor responsible for the acute renal failure. Treatment with the angiotensin converting enzyme inhibitor is associated with an acute increase in serum creatinine, which is a sign of the mild kidney damage. Increased creatinine level are attributed the decline in blood pressure in kidney caused by the inhibition of the renin angiotensin system. Case study which I have is Mrs. J, a 60-year-old widow, had a long-standing hypertension that was unsatisfactorily controlled on a variety of the agents. Her drug therapy included the furosemide 40 mg once a day, amlodipine 10 mg daily, and a salt-restricted diet. Following a routine review of her therapy, ramipril 2.5 mg was added to her treatment regimen in an attempt to improve the blood pressure control. Mrs. J was recently diagnosed with a gastroenteritis. A week after her diagnosis, she presented to her local hospital accident and emergency unit with the ongoing diarrhea. Her BP was found to be 100 by the mg millimeter of the mercury, and serum biochemistry revealed creatinine level of 225 millimoles per liter, while the normal range includes the 50 to 120 millimoles per liter. Sodium found to be 125 millimoles per liter, and the normal range is 135 to 145 millimoles per liter, and potassium 5.2 millimoles per liter has been found, while the normal range includes the 3.5 to 5 millimoles per liter. What was the likely cause and underlying mechanism to this patient's problem? What treatment should be given? Firstly, we have to prepare the soap notes. In soap note, first we have a subject in which the age is 60 years old patient we have, and the gender is female. The complaint is a hypertension and gastroenteritis, which was later diagnosed. Current medication which are utilized by the patient are furosemide 40 mg once daily, amlodipine 10 mg per daily, and ramipril 2.5 mg, which was later on added in the regimen. Objects include her creatinine level a little bit increased to 2 to 5 millimoles per liter, sodium level decreases to 125 millimoles per liter, and the potassium level increases to 5.2 millimoles per liter. And a BP was a check found to be 100 by 60 millimeter of mercury. In assessment, we have patient is utilizing the angiotensin converting enzyme inhibitor, which are ramipril and amlodipine to cure the hypertension on a daily basis will cause the kidney damage by increasing the creatinine level as mentioned in a lab test because of a salt restricted diet for the prevention of the elevation of the blood pressure and later on diagnosed with the diarrhea will lead to the level of the sodium to be decreased. Potassium level has been found little bit increased, showing the kidney is in the initial stage of the damage as it has lost the ability to remove the potassium which leads to the potassium accumulation in the body. Plan which we have is use of the ranitidine and amlodipine will be stopped until the test has been performed for diagnosing the renal arterial stenosis. Patient will be rehydrated with the sodium chloride of the 0.9% as the patient is suffering from severe hyponatremia. After diagnosing, the patient will be start to treat with the low dose of the drugs. In a discussion, we have the administration of the angiotensin converting enzyme inhibitors in patients with a hypertension or a severe heart failure may cause the acute renal failure in the presence of any condition that will induce acute hypertension. In older patients, dehydration caused by the intermittent vomiting and diarrhea is more likely to occur and to produce a hemodynamic instability. Acute tubular necrosis occurs more frequently with protracted hypertension, bilateral renal artery stenosis, or stenosis in the artery of the solitary functioning kidney was less frequent than postulated intrarenal diffuse microangiopathy. On a clinical grounds, renal impairment caused by the angiotensin converting enzyme inhibitor was totally reversible and did not induce the progressive deterioration in renal function. Whether or not the patient had pre-existing chronic renal failure, considering the overall renal prognosis of the acute renal failure in the setting, renal biopsy is not required even in cases requiring the hemodialysis because of the acute tubular necrosis. The risk of inducing the acute renal failure in patients receiving the angiotensin converting enzyme inhibitor can be minimized by using the smallest effective dose, avoiding the agents liable to lower glomerular perfusion pressure. Hypertension and dehydration must be avoided when using the diuretics. That's all. Thank you so much.